we've used Ceribell in the Inspira system, last I checked, over 150 times. And I think it may be more than that now. And so I picked 2 cases that I wanted to highlight. Clearly, there are many, many others that were useful. The first here is an 80-year-old female. She was first admitted to the hospital with symptomatic bradycardia, long sinus pauses, in the setting of using a beta blocker. And she was brought to our ICU. We were letting the beta blocker wash out, and she developed and had witnessed tonic-clonic seizures and was encephalopathic in a post-ictal state in the ICU after. And the question is, is she in non-convulsive status or is she just post-ictal? Without EEG, I think it's going to be very challenging to answer that question. And of course, as all bad things that happened at 2 a.m, you can see in the middle there. And so at 2 a.m, my fellow is sitting there calling us saying, what do I do? And what we used to do, we wouldn't have much choice, either watch or try to transfer to a facility that can do an EEG. And in this scenario, we had Ceribell. We were able to apply the point of care EEG. It showed a 50% seizure burden. We loaded her with Keppra. We gave her Ativan. The seizure burden resolved down to 0%. Her mentation improved, and it says discharged home. Eventually discharged home, not the next day. And she went on to being discharged. And so without Ceribell, it would have really been uncertain whether that seizure persisted. Was she still in non-convulsive status or not? It would have been uncertain if we gave medication, if it worked, if maybe she never was seizing, if we did an EEG the next day. It would have resulted in an immediate transfer. And as I said, that would have ended up in a long delay until actually getting an EEG and confirming seizure activity. With Ceribell, we were able to quickly diagnose, treat, and focus on the primary condition with a positive outcome, of course. Another example, of course, you see this is at 9 p.m., another time when EEG was unavailable. 84-year-old came in with a colectomy. She was admitted to general medical floor, doing well, and then had a hypoxic-mediated cardiac arrest. I believe it was due to aspiration. CPR was performed. We had return of spontaneous circulation, and she was still in a coma state with this kind of rhythmic lip twitching. Of course, intubated by this point, was brought to our cardiac ICU to undergo temperature-targeted management. She was given Ativan due to the lip twitching. It improved the twitching, but still unsure what was happening. We applied Ceribell, and within minutes of her getting to the ICU and being stabilized. And the question is, how quickly can we do it? I think it really depends on how much other medical complexities occurring. If the patient is stable, as soon as we move them to the ICU, we can have the Ceribell machine on and interpreting within minutes. Obviously, if procedures need to be done, there may be a delay. Ceribell in this case showed 0% seizure burden. The next day we did a conventional EEG and it confirmed it. She completed temperature target management, and luckily her mentation improved and she was extubated and discharged home. And I think this to me is one of the most valuable aspects of Ceribell. It's to rule out seizure. I find that so incredibly important in this population. Inspira, and when we're in the community center, our goal is not to become a large neurology, neurocritical care hospital. I want to identify patients who need advanced neurocritical care services, and I want to send them to Dr. Rincon at Cooper to take care of them. What I don't want to do is send patients who maybe they have anoxic and myoclonic jerks. I don't want to send those patients that don't need the care that I'm capable of caring for at Inspira. And that's so important, is that we're trying to avoid unnecessary transfers. I'm not trying to avoid all transfers, just unnecessary transfers. So in this case, we were able to figure out that this was unlikely to be seizure. We were able to keep the patient. We didn't have to escalate medications to try to stop the twitching. We didn't have to transfer the patient, and we were able to discharge home quicker. You can imagine sending them to Cooper and the number of days and time it would take to just to stabilize the patient further. I think the length of stay would have been longer. And so to me, this is the true value of point of care EEG.